Thank you for joining us for our TTC webinar. This is one in a series that we do. We've been doing them roughly every couple of weeks while we've been in lockdown. This one will focus on mild and natural IVF, low ovarian reserve, and optimising fertility. Geeta is the founder and medical director of Create, Fertility and ABC IVF. She's also the lead consultant for Reproductive Medicine at St George's Hospital NHS Trust in London. She's published extensively in the field of natural and mild IVF and the role of advanced ultrasound technology in reproductive medicine. She's the president of the International Scientific Society for Mild Approaches in Assisted Reproduction, and is also the founder and chief executive of Create Health Foundation, a UK charity devoted to promoting women's health, reproductive health. So very impressive. The webinar today will cover natural and mild IVF, the science behind no or low drug approaches in IVF, and who can benefit from these. How to optimise your natural fertility, treatment options for women with low egg reserve, and support and reassurance during the COVID-19 crisis. So the webinar will, I think we might run a little bit shorter just because obviously we've started quite late. But the webinar will run for probably about half an hour, and then we'll take some questions over email, which we've already had earlier, and then we might have time to take some more from you. So if you wanted to ask a question, just hover on over the toolbox at the bottom. You can see there's a Q&A option, and just pop your question in there and we'll try and answer some of those as well.
Okay, first of all, I'd like to offer my sincere apologies to everyone for this delay. Yes, there's some work going on in the local area and lost the internet connection. Sincere apologies from me. And thank you very much indeed for joining this Fertility Network webinar today. And I hope you're all safe and in good health. So I'm going to be speaking to you for the next few minutes about what natural and mild IVF is all about. And also we'll talk about women with low reserve. I'm very happy to answer any questions as regards to optimizing your natural fertility. So I hope you are going to find this educational, and very happy to go through any further questions once we have completed this. So let me just start by saying, what are the aims of ovarian stimulation in IVF cycle? So when we give you drugs for ovarian stimulation, of course, the aim is to try and collect more than one egg and create more embryos and get you have a baby successfully from that cycle. But it's not as straightforward as that. There are a lot more things we do need to achieve with ovarian stimulation, because it's not just a short-term achievement, it's a long-term achievement. So what we want to achieve is to obtain healthy eggs from your ovaries, not just a lot of eggs. Quality matters hugely. And in order to get healthy embryos, we do need healthy eggs and healthy sperm. But ovarian stimulation is aimed at getting these healthy oocytes in order to create healthy embryos. We want to keep the lining of the uterus healthy and ready for implantation while we are doing that. Because the lining of the uterus, which is called endometrium, is hugely important, and that can get affected with ovarian stimulation drugs. So what we don't want to do is adversely damage the lining of the uterus while we are trying to mature more eggs. Because as you know, the seed and the soil are both important for successful conception and having a healthy baby. We want to try and get you to be successful with the least amount of drugs, the least amount of injections, because an increase in quantity of drugs, an increase in quantity of injections, and the duration of your treatment can increase your burden of treatment. So we want to reduce the burden for women. We want to make sure your side effects are reduced and you're not exposed to any unnecessary health risks. And I think those of you who are in this journey of IVF would probably know that there is this condition called ovarian hyperstimulation syndrome. Thankfully, it is rare, but it is something that can happen due to overstimulation due to drugs. So what do we want? Ideally, we want to prevent ovarian hyperstimulation syndrome. We want to make sure no woman goes through this. But if we can't completely prevent it, then at least let's make sure that we reduce it and we prevent the severe form of ovarian hyperstimulation syndrome so that no woman ends up in hospital with that. We also want to ensure that there are no long-term health risks to the woman who takes medication and to the mother. I separate them because not every woman who undergoes IVF ends up with a baby. So we have to ensure that there is no damage done to the health of the woman who has started IVF treatment and didn't take a baby home. And we must ensure that there are no complications for the baby. And there are no complications during pregnancy for the woman as a result of drugs we have given to her during IVF treatment. We want to achieve a fresh embryo transfer. And we all know a fresh single embryo transfer is the best when it comes to achieving better health outcomes for the mother and the baby. And we want to reduce the cost of drugs because affordability is hugely important, whether it is public sector or private sector. We must aim to reduce the cost of drugs and treatment so that more people can access this treatment, both on public service as well as if it is a self-funded treatment. So these are fundamental principles for planning stimulation protocols. So what are these protocols that we are talking about? One is natural cycle IVF, and you may or may not know the first tested baby, Louise Brown, was born as a result of natural cycle IVF. What does this mean? It means that we are collecting naturally selected egg from the ovary and fertilizing it in the laboratory and creating embryo with no stimulation at all. Then there is what is called natural modified IVF, which is something we started to do in, what would I say, around mid-90s, where it felt necessary that we reduce the chance of a woman ovulating naturally if we don't give her any drugs, and to avoid that disappointment and to increase the success of natural cycle, natural modified cycle was invented. So in natural modified cycle, you will receive some drugs. It is for a very minimal period. It could be either in the form of tablets, or it could be either in the form of very low dose injections for anywhere between 2 to 4 days. And the aim of these injections or tablets is to grow or mature your naturally selected follicle, but prevent it from being released before we collect the egg, because that is the one thing we can't do in natural cycle IVF, where we don't have control and many women can ovulate before we collect the egg. Whereas in natural modified cycle, most of the time we're able to achieve that and help women have babies with the most natural form of IVF. So we are dealing with a very low drug approach here in a natural cycle. And then the concept of mild stimulation IVF emerged around 2007. So we are looking at nearly 13 years now. So the concept of mild stimulation IVF is to aim for higher quality of eggs, not just higher quantity of eggs. So the amount of drugs we give you will be lower than conventional IVF. Generally, there is no downregulation phase or suppression phase during this treatment. In other words, in standard conventional IVF, women can take ovarian suppression drugs for up to 2 weeks, anywhere between 10 days to 2 weeks, to suppress your hormones, followed by stimulation for another 10 days to 2 weeks. So the duration of treatment is prolonged, whereas in mild IVF, it's conducted within your natural cycle, lower dosages of drugs are given for a shorter period of time, aiming for mild response from your ovaries. In other words, in conventional IVF, if the aim is to collect around 15 eggs, the aim would be to collect around half of those number in mild stimulation IVF. Okay, and I'm very happy to explain this when you ask me questions, and to aim for higher quality of eggs, not just a huge number of eggs, but also trying to keep the lining of the uterus as healthy as possible during this time, so that we can successfully achieve a fresh embryo transfer for you to be able to achieve a pregnancy and a baby from the fresh cycle, rather than aiming to freeze all embryos because you respond too much and you're potentially at risk of ovarian hyperstimulation syndrome. So the total duration of medication is anywhere between 8 days to 12 days, and then the egg collection and embryo transfer, just as normal. So this is just a graphic representation for you as to what it looks like. This is natural IVF. In natural IVF, we don't give any drugs at all, in a pure natural IVF. So a woman basically comes, she calls when her period comes, and we monitor her growth of the egg sac with ultrasound scan and blood tests. So around 2 to 3 appointments for blood test and scan. And when the follicle is mature, which is a naturally selected egg sac, then we plan the egg collection. For women who don't want any drugs at all, then yes, we will have to deal with egg collection based on their urine test for ovulation. But that, as I said earlier, can be a bit risky only because you may end up with natural ovulation. Or sometimes we can give you a trigger injection in order to facilitate the correct timing of egg collection and reduce risk of spontaneous ovulation. And natural modified is this one, where we may give you injections to block your natural ovulation. And during that time, we need to keep your follicle healthy. And so we will give you a small dose of stimulation injection in order to what we call add-back therapy, to keep your follicle healthy while we are blocking ovulation. And sometimes we can give you tablets only. Then mild IVF looks like this, anywhere between 8 to 12 days of injections, and conventional IVF, apologies here, it is in red and it's not ideal color, but we are looking at a longer duration of injections, and generally the dosages can be higher because of ovarian suppression. So Louise Brown was born with natural IVF, as I mentioned earlier, and this is just to say we need good quality eggs, not just high number of eggs, in order to achieve a healthy baby from IVF treatment. So what are the strategies, or in other words, protocols? From patient's perspective, what does this mean? What kind of drugs we will give, how long we give it for? So in natural cycle, no drugs, as I said earlier. In natural modified, couple of days. And in mild, there are a combination of protocols we can use. So depending on your wish, depending on your ovaries and your fertility profile, we will decide the protocol. So it is tailored for you. So there are many women who don't like injections, and they would like to avoid injections as much as possible. And I have come across hundreds of women who prefer not to have too many injections, or some women who actually have a needle phobia. So there's no reason why we can't help them have a baby if they need stimulation. So those women can have tablets, predominantly tablets to stimulate their ovaries. And sometimes we may add 1 or 2 injections, but this will be very clearly explained to you. And then we use a trigger injection to time the egg collection. So a combination of tablets and injections, or tablets alone with a trigger injection, or a low-dose stimulation injection followed by, or during that time, injections to block your ovulation, and followed by trigger. So altogether, the treatment lasts for anywhere between 10 days to 2 weeks. So let's go through some scientific papers. So why are we concerned about potentially giving longer duration of drugs? Should we be concerned? What is the evidence base at the moment? So this is a paper published from the US, looking at a large number of cycles. As you can see here, more than 650,000 IVF cycles performed in the US from the database. And you can see here all ages, the daily dose of stimulation, which is the follicle stimulating hormone that was administered to women. And then we have different age groups here, under the age of 35, 35 to 39, over 40. So essentially in this paper, what it showed was live birth rate significantly reduced with the increasing dose of follicle stimulating hormone. And this happened regardless of the number of eggs collected. And this large paper also showed that the statistically significant reduction in live birth rate with increasing dose of stimulation remained in patients with good prognosis. In other words, women who have a good egg reserve, women who are younger. So regardless of the number of eggs collected, the live birth rate or taking a baby home was inversely related to the dose of stimulation. So if we look at the biological efficiency of eggs, that how efficient are the eggs that we collect in an IVF cycle in their ability to make babies. So this is a paper from actually both papers are from the US. The first one is looking at conventional stimulated cycles, and the second one is looking at natural cycles in IVF. The first one showed that around 5% of eggs are biologically efficient. In natural cycles, the paper showed with large data that around 26% of eggs are biologically efficient. So natural cycle eggs seem to be 5 times more biologically efficient than conventional stimulated cycle eggs. So when it comes to their ability to make babies or biological efficiency, natural cycle or naturally selected eggs seem to be superior from these two studies. In other words, in conventional stimulated cycles, you do need a large number of eggs in order to achieve the success. So this is another US paper looking at the dose and its relationship to the normality of eggs, once again showing higher the dose, lower the number of normal eggs. This is study from the Netherlands, a very good prospective randomized study, in other words, very well designed study, looking at the comparison between conventional mild and mild IVF as in relation to embryo quality. So these were prospectively designed arms. Therefore, in conventional IVF, there were 8 embryos because the aim is to generate more embryos in quantity. And here in mild stimulation, the aim is to generate or collect or create less embryos. So here you have 8 embryos, good ones, and here you have 4. But as part of this study, the group decided to do embryo biopsies to check how many of them are actually chromosomally normal. I wouldn't suggest that you should get your embryos biopsied unnecessarily. That is not something we would recommend. But this is a part of a research study that was done. And in that study, they very clearly showed that in conventional IVF, there were 2 normal embryos. And in mild IVF also, there were 2 normal embryos. So it just goes to show there was equivalent number of normal embryos and there were more abnormal ones. In other words, the proportion was higher when it came to abnormal one in conventional IVF compared to mild IVF. This is really to understand the effect of potentially the stimulation and the dosage and the duration and how we do that on the quality of embryo and the normality of embryo. So this is a paper looking at a large database. That's our UK database from the Human Fertilization and Embryology Authority. And the group showed that if you collect a very high number of eggs, in this case 20, then you put back in an embryo in the same cycle when you have collected a high number of eggs, then the babies from that cycle are more prone to be premature or being low birth weight. So a very high amount of estrogen that is created in a woman's blood during that cycle could be linked to this adverse effect on babies. So it is not only about the effect on the woman, because every woman who takes drugs during IVF treatment knows that it does increase burden of treatment for her. It can increase side effects. It can potentially have health risks depending on how her ovaries respond. But this is showing also about the effect potentially on babies if we put back in fresh embryos. So we don't want this. We don't want babies to be born premature or to be of low birth weight, because we all know that low birth weight and prematurity can have potential long-term health impact, and we want to prevent that. So this is about the egg number. I won't go into that because I've already covered that. And so this is a paper looking at the clinical significance of collecting a low number of eggs following mild ovarian stimulation in IVF. It's a meta-analysis, a really good paper, which is an analysis of randomized controlled trials looking at the mild cycle with conventional stimulated cycle. And if you see here, this is number of eggs, and here is the implantation rate. So it actually shows that the implantation rate has been higher here, even in the presence of collection of low number of eggs. So these findings should reassure all of us that obtaining low number of eggs is not something to be worried about, because it can have a positive impact on implantation and can have a positive impact on the actual outcome of cycle as regards to babies. So several reports over the last 13 years, if I can be more precise, have shown that egg quality can be improved with less medication or less stimulation in IVF cycles. So I'll just take you through a few studies. This is looking at normal responders, in other words, women who respond normally. So there are women who have got low egg reserve, and we call them poor responders. Sorry about the term, because it means that they don't respond well. They are low responders because of low egg reserve. And those women who have got high egg reserve, such as women with polycystic ovaries or polycystic ovary syndrome, are called high responders because their response is high. We collect a lot of eggs from them. Whereas women who have normal ovaries with normal egg reserve are called normal responders. In this situation, if we look at this study looking at optimum dose of stimulation in normal responders, 150 international units per day, even if you collect, because this is comparing the 150 IU dosage with higher dosages such as 200 to 250 IU, it basically shows that even when you use low dosage of stimulation and you collect low number of eggs, you can get similar pregnancy rates and similar number of good quality embryos to freeze. Hope it is reassuring, this study. And if we look at high responders, which is what I said earlier, women particularly with PCO, once again looking at mild cycle, using no downregulation as opposed to using downregulation, there seemed to be no difference in live birth rate or cumulative live birth rate, which means including frozen embryo transfer, and there was no difference really in cancellation rate. So once again showing there is no need for ovarian suppression in this situation. If we look at poor responders, women who have got low egg reserve, a really good study looking at low dose, in other words, women who actually have low egg reserve, in them to give them lower dose of stimulation of only about 150 international units, as opposed to conventional stimulation with higher dose of stimulation. I say this because there is still a belief that many women say, look, I have low egg reserve, can you please give me high dose stimulation so that I can get more eggs and get better result. This is evidence to show that is not the case, that even you compare beautifully designed studies, high dose stimulation in conventional IVF with low dose stimulation in mild IVF, there was no difference when it came to ongoing pregnancy rates, clinical pregnancy rates, despite using low dose stimulation. And the total dose of stimulation was quite a lot lower in mild cycles. As you can see here, more than 3,000 international units. And there was a similar cancellation rate and similar number of top quality embryos. This is to say you can achieve equivalent results by using mild stimulation compared to conventional stimulation in women with poor response. This is a paper that we have just published. It's online already. It is due to be published in print soon. So this is women who are low responders, in other words, women who have got low egg reserve. We collected evidence from all published randomized controlled studies. These are properly designed, high-powered studies, and looked at live birth rates, high-grade embryos, stimulation dose, and treatment cost. So these are the number of studies we analyzed. And once again, this paper shows that there was no difference in live birth rates for mild versus conventional. There was no difference in cycle cancellation. There was no difference in high-grade embryos. And stimulation dose was much higher with conventional IVF, which is expected compared to mild. And the treatment cost was much lower with mild stimulation compared to conventional. Once again, to show that you can obtain similar results by reducing the drug dosage, by reducing the duration of treatment for women with low reserve. This is another paper which we have just submitted for publication, where we have looked at normal responders as well as high responders and compared mild with conventional. So looked at a number of randomized trials published in scientific literature and looked at live birth rates, the incidence of ovarian hyperstimulation syndrome, high-grade embryos, the stimulation dose that was given to women, and treatment cost. And this paper is showing, I have to say, this is paper that is submitted for publication at the moment, that there was no difference in live birth rates. The incidence of ovarian hyperstimulation syndrome was reduced with mild stimulation. This is in normal and high responders, and no difference in high-grade embryo. Higher dose of stimulation given in conventional stimulation, and treatment cost was much lower in mild stimulation. So overall, what I have tried to show to you based on published, peer-reviewed, good quality scientific papers, that there is no difference in success rate when it comes to taking a baby home, but we can reduce ovarian hyperstimulation syndrome, we can reduce treatment cost, and we can reduce the duration of treatment and burden of treatment for women with mild stimulation. So because of a number of scientific papers that have been published in recent years, the American Society for Reproductive Medicine actually came up with these recommendations in late 2018, saying that in women with low egg reserve who are classified as poor responders and who are pursuing IVF, strong consideration should be given to a mild ovarian stimulation protocol, because you achieve the same result compared to traditional or conventional IVF. So the place for mild stimulation is increasing, even in women with low reserve, because of equivalent results and reduced cost and burden of treatment. So if we if we look at the, sorry about this, seem to have jumped. If we look at the cost of treatment, there are a number of papers published, scientific papers published in the last, what I would say is, well, over a decade, comparing mild and conventional IVF. And when we compare, we have to compare the cost of medication, we have to compare procedure related, and in fact, we have to, in my view, if we are looking at the cost of any intervention in medicine, we cannot just look at the short term, and we can't just look at the cost of that medication or intervention. We really need to look at the bigger picture in health economics as regards to if it is likely to give more complications. So what is the cost of treating that complication? Okay, and if it is likely to give any pregnancy complications, then what is the cost of additional antenatal care? And if there is an increased likelihood of having low birth weight babies and premature babies, what is the likely cost of treating that on our public health service? Because that is enormous, and if there are any long-term health risks. So we cannot be short-sighted when it comes to measuring the cost of any intervention. We really need to take the approach that we add everything up, because the cost is to the patient and the cost is to the society, and all of those need to be considered. And in this studies, quite clearly, the long term or the other costs that I have just mentioned, where I deeply care about, are not, but even then, every single trial estimated the cost of mild IVF to be less than conventional IVF. And I think we do need to care about that, whether it is a patient paying from her own pocket, or whether it is our public health service paying from taxpayers' money. So what can mild IVF offer based on the scientific evidence to date? It can offer equivalent success rates to conventional IVF. It can reduce the cost of treatment. It can reduce the number of visits for the woman, and it can reduce side effects and complications, and particularly complications such as ovarian hyperstimulation syndrome and thrombotic events such as deep vein thrombosis or clot in the lung. So reducing discomfort and stress and disturbance to everyday life is established, and that is quite important, and it can lead to better health outcomes for mother and baby, which is so important for us, for our society, for families. So let's move on to natural and natural modified IVF. Who is that specially applicable to? Natural and natural modified IVF is specifically applicable to women who have got low egg reserve. They seem to benefit from that. It doesn't mean others can't, but others can benefit from stimulated IVF because their success rates per cycle can be higher with, for example, mild stimulated IVF that I have demonstrated. And whereas women who have low egg reserve, where there is no additional benefit of giving high stimulation, then natural and natural modified IVF can give them that result they desire or deserve. So women with low egg reserve, in other words, women who have got low AMH, low count of follicles in their ovaries, women who are older, women who have previously had conventional IVF and have not got pregnant despite having few more eggs, and women who have previously failed to implant can also try. Women with family history of estrogen-dependent cancer, where they want to reduce their exposure to drugs, can also benefit from natural and natural modified IVF. Women with malignant melanomas, women who have got severe endometriosis, where they would like to take less drugs, as much as possible, limit the amount of drugs they take so that they do not increase their potential reactivation of endometriosis due to increasing estradiol levels. They can benefit. Women with cancer can opt to that. And essentially, women who feel they want to avoid drugs and associated risk and discomfort. But what is important for you is to make that informed decision after getting your success rate with natural modified IVF compared to what it would be with the stimulated IVF. And these women with low egg reserve are the ones they seem to be benefiting from this, because their results are no higher from conventional stimulated cycle. But when it comes to natural modified IVF, it can be quite tricky in managing that cycle, because we are relying on your own naturally selected egg as well as your own cycle. So it does require very close monitoring and optimization of your success. It also requires experience and skill, and it requires dedication to working 7 days a week as necessary, because that is quite important in achieving that success with natural modified IVF. So what about outcomes for babies? Is there any work that is being done comparing the outcomes for babies with natural and natural modified as opposed to conventional IVF? Yes, there is a meta-analysis that has been published, a systematic review, a very high quality paper, and looking at perinatal outcomes for babies after stimulated versus natural IVF. And this paper showed that the risk of a baby being premature or being of low birth weight was significantly higher after stimulated compared to natural or natural modified IVF. So once again, to show that women can benefit not only for themselves because they take less drugs, they are going with a naturally selected egg and less burden of treatment and less cost, but also for babies, because babies can potentially be more full-term or normal weight, and we can reduce their future health risks. So to maximize the success of natural and mild IVF, quite clearly, of course, we have to believe in quality and not quantity approach. And we have to be able to evaluate the quality of each follicle, because we are not relying on a huge number of follicles. We are relying on a quality of individual follicles. And what we do from our experience is we use advanced ultrasound technology like Doppler, or assessing the blood flow to each follicle, so that we try to assess the quality of follicle indirectly. And we also try and see if we can increase the blood flow at any stage of your cycle, not only just for the follicle, but also for the uterus, in order to increase your chances of implantation and chance of having a healthy baby. And as I said earlier, extremely important that the clinical staff are not only trained in this, but also skilled in delivering a successful natural and mild IVF therapy. And 7-day-a-week work as required in order to give you the very best chance of success you deserve. So this is just to show an example of what the blood flow to the follicle looks like. And those of you who have had scans would recognize this black circle, which is a follicle or an egg sac on ultrasound scan. Whereas this color you see around that is what I would call the blood circulation, or what we would call follicular blood flow. And we measure that by using a graph like this, and to look at what we call peak systolic velocity, which is the speed with which the blood flows to that egg sac, which is what we take as an indirect measure to assess the quality of the egg. This is the first paper I published in mid-90s, looking at the relationship between the blood flow to the follicle and whether we get an egg, and what is the quality of the egg we can obtain. And that showed positive relationship between blood circulation to the follicle and the quality of the egg we obtain. In other words, if you've got good blood flow to your follicle, we are more likely to get an egg, and that egg is supposed to be of higher quality because of better oxygenation to that follicle, and the cells surrounding the follicle being healthier and optimal for maturity. And my colleague, Professor Van Blarcom from Colorado, sorry about the noise, went on further to study the blood circulation as well as the oxygen content in each follicle. And he also demonstrated that if the blood flow is low and if the oxygen levels within follicles is low, then it is likely that the quality of the egg will be affected. And he looked at more than 1,000 follicles. And we have been working along with Professor Campbell very closely for nearly 2 decades in trying to better this technology, as well as trying to use this technology in order to help women so that we can assess the quality of their blood eggs by assessing the blood flow to them. the follicle and see whether that is adequate for making decision to go ahead with egg collection, or whether we can improve it during that cycle, and how can we achieve that. This is ongoing work as well. This is just to demonstrate to you the blood circulation to the lining of the uterus, because if the blood circulation to the lining of the uterus is good, then it's more likely to be receptive for implantation. So let me just take you through some of the success rates. And I have to say these are success rates from us, from Create Fertility, because we use mild stimulation IVF. And you just to demonstrate that this is the success rate, ours at the orange bar is the national average success rate, that with mild stimulation IVF, you can achieve good success rates. And in all columns here, the success rates are higher than national average, yet to demonstrate to you that this is achievable and has been achieved. So there is no worry about reducing your success rate at all. And this is looking at per embryo transferred, because we care deeply about reducing multiple births and actually transferring a single high quality embryo so that there are better health outcomes for the woman and the baby. So once again, per embryo transferred here, and these are live birth rates per cycle. These are just to show even per embryo transfer, you can transfer in younger women, in women under 38, good success rates achieved, and ongoing success rates for several years. So I won't go too much into that, because this is something that's available on a regulator's website as well as our own website. But this is for me to reassure that these success rates are achieved here. It's natural cycles once again. But remember, I said natural cycle is really offered to women with low egg reserve so that they can benefit with natural selection and they don't have to take additional unnecessary stimulation medication if it is not going to improve their success rate and particularly health outcomes. A natural and natural modified can be given in cumulatively, can also achieve high success rates. So I'm coming up to first of all, my apologies again for starting late. I feel terrible about that. So I'm just coming to close, I think, my talk. So the aim of IVF treatment has always got to be, in my view, to achieve a singleton, healthy, full-term, normal weight baby with no short and long-term health risks to mother and baby, and to achieve that at the lowest possible cost. That is not only holistic, but also looking at the long term for the society. So I've already explained this slide about its advantages at a level of gametes like eggs and embryos, as well as for the woman when it comes to long-term health. So apologies for starting late, and I hope that was okay, and I was able to demonstrate some scientific evidence to you. And thank you for your attention, and thank you for being patient. And thank you very much, Rosa, for being so patient.
Don't worry, these things
happen. Of the technical side.
Yeah, these things happen, don't they? So thank you everyone for hanging around, and I hope and I'm sure you got masses of valuable information from Geeta. We do have some questions that have come in via both the chat box and the Q&A. So Geeta, I'm not sure whether you want to have a look at those questions and decide which ones that you want to answer, or whether you'd prefer me to just go through them if we've got time.
Do you mind? Because I'll tell you what, I can't, two things. One thing is I can't hear you very well. Secondly, I don't have those questions with me because I kept moving from computer to computer in order to get this fixed today.
Yeah.
Do you mind asking them to me and anything else that has come so that I can answer those questions?
Yeah. Okay, so I'll just start. I'm going to do these in time order, everyone, just so that we just to find the fairest way to do it. So hopefully we'll get through all of them, but let's see. So I have been diagnosed with very low AMH, just completed 3 months of Clomid and trigger shots. The last 2 months were unmonitored via scans and blood tests due to COVID. We've been told that IVF won't work for us due to my diminished ovarian reserves. It seems the only option we are being offered on the NHS is donor egg option. Is this correct?
Yes, I mean, yes, unfortunately on the NHS, one of the criteria at the moment is that you do need to have normal egg reserve, and that seems to be consistent across many CCGs. So that may be true on the NHS, but if you have low AMH or low egg reserve, that doesn't mean you can't have a baby with your own eggs. It's just that the chances are lower because of lower quality and lower quantity of eggs. And I don't know, I mean, clearly, I don't know which CCG you are under, which is your hospital, but if you are excluded from the eligibility criteria, it's probably going to be difficult for you to achieve that on the NHS. If they are going to offer you donor eggs, I don't think you should stay on the waiting list for donor eggs so that you don't lose out on that. But if you'd like to explore the possibility of having a baby with your own egg with the techniques that I've just demonstrated with something like natural modified or mild IVF, because it has got a totally different approach, then you could explore that. But the only trouble here is whether you'll have to do it on a self-funded basis. So if you'd like to discuss that further, you can send your details to Rosa, and then we can have a further discussion to see which CCG you come under, whether there's a possibility of achieving that on the NHS for you, which should be the first option. But certainly the chances are there, the chances are reduced, but not zero. Thank you.
Okay. I've been taking prenatal supplements and CoQ10, vitamin E, D, C. Are there any other supplements I can take that might help? I've been TTC for 18 months and I'm 38 this year.
Yes, you know, what we normally say is you need to take folic acid. It's essential when you're trying for a baby. Vitamin D can help. In my view, if you have a healthy, balanced diet and a good lifestyle, then there is really no need to take any additional supplements. Folic acid, yes, absolutely. Vitamin D can help, but there is really no need to take anything else. And I think you're already taking plenty more anyway.
Okay. Have you any experience of working with women who need mild or natural IVF due to other health conditions? For example, multiple sclerosis, which may be aggravated, I believe, by aggressive hormone situation. Thanks.
Absolutely. Absolutely. We have women come to us from not only all parts of the country, but also from other parts of the world because of their existing health conditions where they are not allowed to take stimulation because stimulation is contraindicated in some conditions. And in some conditions, it's advised that you do not take higher dose of stimulation. And yes, absolutely, we have a lot of experience in helping women with existing medical conditions where we can help them with no drugs or less drugs. At least to try would be quite important, because if we don't try, we don't know. Thank you.
I had an allergic reaction from my trigger hormone injection. The egg retrieval still took place, but would these eggs be healthy enough?
Well, if the egg collection happened and you managed to get mature eggs, there is no reason to believe that those eggs won't be healthy, because I think the allergic reaction is more to do, I don't know the detail of your allergic reaction, it would be good to know, but I do not believe that it has affected the health of your eggs, particularly if the clinical team, if they have told you that you have got mature eggs which look good under microscope, there is no reason to be concerned about possible problems with those eggs.
Okay. Gosh, I've just seen how many more questions we have, so let's take a few more, but I don't know how much time you've got, Geeta, or how much time everyone else has got, but let's keep going for a bit. Regarding your study that is awaiting publication, it states that live birth rates are no different for low responders in both high and low dose stimulations. So does that mean that if you don't respond well to high doses, then you are no more likely to have a baby than if you switch to low doses? Sorry if I've confused the question.
I think it's okay. Let me give an answer anyway, because clearly I'm not sure quite exactly. So our paper for low responders is already published. It's online. The paper with normal and high responders is the one which is submitted. But there are other papers published in these groups anyway. Ours is just putting all papers together. So if you clearly have what they are showing basically is whether you have low egg reserve, normal egg reserve, or high egg reserve, mild stimulation can give you equal results and can reduce complications and the cost of treatment. So if you have already taken high dose and you haven't got pregnant, that doesn't mean mild won't work. To be honest, one should try because the lining of the uterus could be healthier due to less drugs. And there may be an element of that helping with implantation as well. So we need more details quite clearly, but with basic information that I have got, I can say that. And Rosa, I'm very, very happy to answer questions offline and send them by email to you.
Great. Yeah, okay, if we don't get through all of them, then I'll share them with you and we can work out how to do that. Yeah.
Yeah.
So let's take just a couple more. So I'll just take the next two. I'm sorry if we didn't get to your question. It's just that I'm doing them in time order. So can I please ask the following? If you had a large 8 centimetre endometrioma,
endometrioma.
This on one ovary, I've got one of those, so I should know how to say it. Does that mean the endometriosis is classed as mild, moderate, or severe? And number 2, does severity of the disease affect your chances of conception?
Yeah, well, so that's a really good question. Clearly, 8 centimeters is a very large cyst in your ovary, so it is likely to have affected. It is likely to have, I have to say, because I don't know your age at the moment, I don't know your egg reserve and your hormonal parameters. But if it's affected your egg reserve or quality of eggs, clearly it is likely to affect your outcome. But it would be quite interesting to know more details as to whether your ovaries are mobile when we do a scan. Is there any scar tissue in your pelvis? All these we can elicit with targeted ultrasound so that we can establish if there's any scar tissue, if there are any other, what does the other ovary look like, and what the blood flow within your ovary, and what the antral follicle count, which is the follicle count is, because all of them are important. And also sometimes to understand whether you have what is called adenomyosis. And adenomyosis is a condition which affects the uterus, the wall of the uterus, which is an endometriosis condition, whether that is also affected. All these matter when we actually discuss your risk. But what's important is that particular ovary with 8 centimeters, whether the follicles are seen, what is the effect on the ovary, how severe it is. That's something we really need to check because it doesn't necessarily mean it's severe endometriosis. Thank you.
And final question. So I have low AMH of 5.5 and endometriosis. Could I have this treatment? I have had 2 failed cycles where I did get 1 embryo fertilized and implanted each time. I'm really struggling with the hormones and was very sensitive to them. So I'm interested in having a lower dosage with less side effects.
Yeah, thank you. That's a very relevant question to me because that's a sort of woman who can really benefit by trying a natural modified or even mild stimulation for 2 reasons. One is, you have only had 1 embryo anyway, so why take more medication to achieve that? That's something we can achieve with natural modified. Secondly, you have endometriosis, and therefore reducing the dosage of stimulation would help you as regards to keeping your endometriosis in check. So definitely worth exploring further to make an informed decision. Thank you.
Okay. I just want to apologise for anyone that sent in questions via email. I'm sure that what we'll do is if you can all, those of you who have already done that, don't worry, I'll pass those to Geeta with your email address as well. And those of you that we haven't answered your questions, then you'll find my email address in Zoom. You'll get an email tomorrow just saying thank you for the webinar, and my email address is in there, or you'll already have it from the invite that you were sent. Just send your questions in and I will forward them over to Geeta, and then we'll make sure that we get them answered for you. So thanks again for waiting for us. And Geeta, thank you so much for coming on and hitting the road at full speed after you'd been in that terrible technical situation. But yeah, I hope you've all enjoyed the webinar, and I hope it's been really useful for you. So thank you very much.
Could I just say a big thank you to you, Fertility Network UK, and to everyone who joined us, and stay safe.
Oh, that's lovely.
Yeah, stay safe and, you know, stay healthy. And we are all here to help you through your journey. Thank you very much indeed.
Yeah, thank you, everyone.
Thank you.
All right, bye-bye.
Bye.